All right, if you're gearing up for your postgraduate exams, you know there are certain topics that just keep popping up. Well, non-tuberculous mycobacteria, or NTM, is definitely one of them. These guys are, and I mean this literally, everywhere. But here's the problem. They're masters of disguise, often looking exactly like tuberculosis. Nailing the diagnosis and management is absolutely critical, not just to pass your exams, but for your patients. So let's break down exactly what you need to know to get this right. So picture this. It's a classic exam question, right? You've got an older patient, she's got some underlying lung issues, and her sputum comes back positive for acid-fast bacilli. The knee-jerk reaction, the one that's almost automatic, is to shout TB and start treatment. But hold on, what if it's not? That single assumption can be a huge clinical error. This, right here, is the entire puzzle of NTM, and we're about to give you all the pieces to solve it.
Okay, so first things first. Before we can fight the enemy, we need to know who we're dealing with. Let's get a clear definition and see where these organisms fit in the grand scheme of things.
The definition itself is pretty simple, really. NTM is basically the catch-all term for every mycobacterium that isn't the cause of TB or leprosy. Now, you might see it called MOT, but the most important term here, the one I want you to burn into your brain, is environmental. See, unlike TB, which is a human problem, NTMs are just out there. They live in the soil, in our tap water, even in the shower heads and plumbing of our homes. We're all breathing this stuff in constantly. But, and this is a huge but, you don't catch it from another person. That's a game changer.
Let's put these two side by side, because this is the core concept. Think of TB as an obligate pathogen. It needs a human host to survive and spread. It's passed person to person, and it has that sneaky ability to go dormant for years. NTM, on the other hand, is an opportunist. It's perfectly happy living in the environment and only causes trouble when it stumbles upon a person whose defenses are weakened. There's no latency, no person-to-person spread. Getting this distinction straight is the absolute foundation for everything that follows.
All right, here's a true exam classic. It's a bit old school, but you have to know it, the Runyon classification. It's all based on growth rate and pigment production. Group I are the photochromogens. Think photo for light. They make pigment only when you shine a light on them. Your key player here is M. cansauzi. Group 2 are the scotochromogens. They produce pigment in both light and dark. Group 3 are the non-chromogens, no color at all. And this group contains the heavyweight champion of NTM, the M. avium complex, or MAC. And finally, Group 4, the oddballs. They're the rapid growers, showing up in the lab in under a week. The one you really need to remember here is the nasty M. abscessus.
So, a question should be forming in your mind right now. If these bacteria are in our water and soil and we're all exposed, why isn't everyone sick? Well, that's because the story of NTM disease isn't really about the bug. It's all about the host. Let's trace that path from just breathing it in to actually getting sick. It really happens in 4 steps. Step 1, exposure. We all do it every day. Step 2, colonization. The bugs land in our airways. Now, for most of us, that's where the story ends. Our immune system is like a bouncer at a club. It kicks them right out. But then comes step 3, the critical turning point, a breakdown in host defenses. This is when the bouncer gets distracted or overwhelmed. The NTM gets past the velvet rope, and that's when colonization becomes a real infection, leading to inflammation and ultimately lung damage. So what causes this breakdown? Well, you can think of it in 2 big buckets. The first, and by far the most common, is a problem with the lungs themselves, local immunity. Think of conditions like bronchiectasis or COPD. The architecture of the lung is damaged, so it just can't physically clear things out properly. The second bucket is a problem with the whole system, systemic immunity. This is what you see in patients with advanced HIV, organ transplant recipients, or people on drugs like TNF-alpha inhibitors. And in very rare cases, there are genetic defects, like in the interferon gamma pathway, which is just crucial for our bodies to fight off mycobacteria. So when the defenses do fail and NTM gains a foothold, what does it actually look like? Well, it's not just one thing. NTM can present in a few classic ways, and you've got to be able to recognize these syndromes. By far, the most common presentation is lung disease, which itself comes in 2 main flavors. You've got the fibrocavitary form, which looks a whole lot like classic cavitating TB, and you typically see it in older male smokers with COPD. Then there's the nodular bronchiectatic form, which has the famous nickname Lady Windermere syndrome. This is classically seen in thin, older women who tend to suppress their cough. Outside the lungs, you can see lymphadenitis, which is actually the most common NTM disease in kids.
Then there are skin infections, like the classic fish tank granuloma from cleaning an aquarium. And finally, you have the most devastating form, disseminated disease, but you really only see this in people who are profoundly immunocompromised. Okay, let's move on to what is arguably the trickiest part, and a guaranteed focus for any exam, the diagnosis. This is tough because, remember, these bugs are everywhere. So just finding one in a sputum sample doesn't mean anything. You have to prove it's the culprit, not just an innocent bystander. The key to diagnosis is what we call the three-legged stool. You need all three legs for it to stand. You need the right clinical picture, the patient's symptoms. You need the right radiological picture, what you see on the scan. And you need the right microbiological proof from the lab. If you only have one or two, the stool topples over. The diagnosis isn't secure. You need all three. No exceptions. Now, this table. This is pure gold for your exams. These are the official ATS/IDSA criteria, and you just have to know them cold. So leg 1, clinical. The patient has to have the right symptoms, and you've ruled everything else out. Leg 2, radiological. The HRCT needs to show classic features like cavities or that nodular bronchiectasis pattern. And now for leg 3, microbiological, which is the most stringent. You need at least 2 separate positive sputum cultures. A single one is not enough. Or you can have one positive sample if you get it from a bronchoscopy, or if you get it from a lung biopsy. That single positive sputum is the biggest trap. Remember, that's just colonization until proven otherwise. So let's walk through how this works in practice. It starts with suspicion in the right patient. You get an HRCT and it looks fishy. So you collect multiple sputum samples. The lab calls you back and says, hey, we grew an NTM. This is the crucial moment. You do not jump to treatment. You pause, you take a breath, and you rigorously apply those three-legged stool criteria. If everything lines up, great, you've got your diagnosis. If it doesn't, the patient is colonized, and the right move is to just watch and wait. So, after all that work, you've finally confirmed diagnosis. Now it's time to treat. And this is another area where NTM and TB are worlds apart. NTM treatment is a long, tough road. The drugs can be toxic, and most importantly, there is no one-size-fits-all regimen. It all depends on the exact species you're fighting. Let's start with MAC, the most common culprit. The absolute backbone of any MAC treatment is a macrolide, like azithromycin. Now, for the less severe, nodular disease, you can often get away with a 3-drug oral regimen given just 3 times a week. But if you're dealing with severe cavitary disease, you have to hit it harder, daily therapy, and often you need to add an IV drug like a amikacin at the beginning. And then there's the duration. Just look at that. It's not just 12 months of treatment. It's 12 months of treatment after the patient's cultures have already turned negative. That is a massive commitment. Okay, now for M-Canzacin. Here's the high-yield pearl for this one. Just look at that regimen. Rifampin, isoniazid, ethambutol. Does that look familiar? It should. It's basically standard TB therapy. This is a huge exam point. M-Canzacin is much more sensitive to these drugs, making it one of the more treatable NTMs, with really high cure rates if you get it right. And then there's Mycobacterium abscessus. To put it plainly, this is the villain of the NTM world. It is notoriously, stubbornly resistant to almost everything. Treating it is a marathon, not a sprint. It starts with a long, intensive phase with multiple IV antibiotics, followed by a continuation phase with a cocktail of oral drugs that you have to pick based on complex lab testing. Honestly, this is not something you manage alone. This is when you pick up the phone and call an expert. It's one of the toughest challenges in infectious disease. Whew, we have covered a ton of ground. So before we wrap up, let's just boil it all down. Let's put NTM and TB head-to-head one last time to crystallize the differences that are so critical for your exams and your practice. Let's do a rapid-fire comparison. Source: NTM is environmental, TB is human. Transmission: NTM is a no, TB is a yes. Public health response: for NTM, there's nothing to do. For TB, it's a full-on investigation. Diagnosis: for NTM, finding it is just the beginning. For TB, finding it is the answer. And treatment: NTM is a complex a la carte menu depending on the species. TB is a standardized 4-drug combo meal. If you can remember these 5 points, you are well on your way. Now, for the money shot. How do you structure a perfect 10-mark essay on this? Here's your template. Start your introduction by defining NTM as an environmental organism and stressing the need for strict criteria. For diagnosis, explicitly name the ATS/IDSA criteria and its 3 pillars. For management, drive home that treatment is species-specific and prolonged, and give a specific example, like the MAC regimen. And for your conclusion, just bring it all together. The key is to differentiate colonization from disease and tailor the therapy. Follow that structure and you'll do great. All right, let's finish with a quick Viva practice round. Ready? Question 1. What are the 3 pillars of diagnosis? That's clinical, radiological, and microbiological. Question 2. How does treatment for cavitary MAC differ? It's daily therapy, and you usually need an initial IV drug. Question 3. What's Lady Windermere syndrome? That's the nodular bronchiectasis disease, classic in thin elderly women. Question 4. Why no monotherapy ever? Because you'll breed resistance in a heartbeat. And finally, question 5. Which NTM is treated like TB? You got it. It's Mycobacterium canzi.
So I'll leave you with one final thought to chew on. We spend all this time learning how to treat NTM in our patients, one person at a time. But the source of the infection isn't another person. It's coming out of our taps, our pipes, our soil. As our population ages and more people have chronic lung diseases, we're going to see more and more of this. So does that mean we need to start thinking bigger? Is this not just a clinical problem, but a public health and infrastructure problem? It's a complex question, but it shows just how connected our work is to the world all around us.